Let's continue with the review. This is part 2 of the 1201 final exam review. All right, let's talk about substance use disorder. And let's talk about the CWA, which is a tool to evaluate the signs and symptoms of acute withdrawal symptoms. Please review the CWA form that's in the course and the elements that are on that form. What do you review? What do you assess when you're assessing for withdrawal symptoms? One of the things is feeling nervous. So we're not asking people, why they drank or, about their history. It's about the here and now and how they're feeling. And one of the assessment points is how nervous they're feeling. Look at the signs and symptoms of alcohol withdrawal syndrome. And what are some of those symptoms? The person will be oriented. They may have coarse tremors, anxiety. They might be sweaty. They might have some stomach cramping. And these symptoms are going to start within about 24 hours of their last drink. Probably sooner, but definitely by 24 hours after their last drink. And that will be alcohol withdrawal syndrome. For somebody who's been drinking heavily and regularly, it is not safe for them to stop drinking suddenly without medical supervision. Alcohol withdrawal can be life-threatening, and detox should occur under medical supervision. Also review the drug dilsulfiram, which is Antabuse, is the trade name. So Antabuse is a pill that someone can take. Now, this pill does not prevent cravings. It does not prevent someone from drinking. It's a deterrent. It's a little bit of support so that the person knows that if they drink while on this pill, they will get really sick. They'll throw up, they'll have stomach cramps, probably have some diarrhea. There's a severe adverse reaction that occurs. And because they know this, that should be the deterrent for them not to drink. So they'll also get a throbbing headache. So it's a good deterrent, but it's not a prevention. So it's really meant for the stable person in recovery. If someone is at risk for drinking and, we don't think that they can really remain stable and sober, this is not the best drug for them because it's dangerous to throw up and have diarrhea. Why is it dangerous? Because then someone gets dehydrated, you can get arrhythmias. So yeah, we don't want someone to be throwing up, but we want that threat to keep them from drinking. So I hope that makes sense. Let's see. When giving someone methadone for opiate addiction, methadone should be meeting that physical craving that someone is having for opiates. It's a synthetic opiate, and it's used as a substitute for heroin in a lot of maintenance programs. Generally, clients take 1 daily dose of methadone. And it's just enough to prevent cravings, or to meet the physical need and not produce cravings for more. It does not make someone high at a prescribed dose. Of course, if you buy it on the street and take enough of it, of course it can. Yeah. Let's see. Review codependent behavior. Codependent behavior is a behavior that appears helpful on the surface, but in actuality can prolong the negative behavior. And in the case of addiction, the behavior can appear helpful, but actually supports continued addiction. In thinking about a nursing care plan, carefully think about each piece of the care plan. There's a question on evaluation of nursing outcomes. So think about, how do we evaluate nursing outcomes? Think of some sample outcomes. For instance, maybe your outcomes are identify let me see. Hold on one sec. Maybe you've asked the patient to identify three things that lead to their drug use. And if you're working on evaluation, if the client has identified those things, then that outcome is met. If they're not able to identify those things, the outcome is not met. So think about what it means to evaluate nursing outcomes and client outcomes. 12-step programs. 12-step programs require that clients abstain from all substances. So 12-step programs are based on abstinence. All 12-step programs, whether it's Alcoholics Anonymous, or Narcotics Anonymous, Overeaters Anonymous, Gamblers Anonymous, all 12-step programs require abstinence. All right, let's talk about depression and get into some of the medications that we'll see in the treatment for depression. So let's talk about Prozac, which is fluoxetine. Side effects. One of the major side effects with Prozac is sexual dysfunction, which seems like, it may or may not be a big deal when we're comparing it to suicidal ideation. But if you think about someone in their 20s, 30s, when people generally are getting together and getting married and wanting to start families, or just in normal ages of dating a lot, sexual dysfunction could be a really big deal to someone. And if it's that big a deal, then it's certainly not going to be helpful for their depression. So it is something that needs to be considered and talked about, recognized. When we're talking about lithium, which is Escalith, but more often just called lithium, you should know the normal values of lithium level, what's therapeutic, what is not therapeutic, which means below the therapeutic level, and what would be toxic. So less than 0.5 are not really therapeutic, and more than 1.5 is considered toxic. And and please understand what signs and symptoms you would expect to see with lithium toxicity, right? If someone has a toxic level of lithium, you'd probably see nausea, diarrhea, confusion. Let's see, if somebody has bipolar disorder and they have been manic for, let's say they've been manic for several weeks and they haven't slept in several days, the first thing that you want to assess is you want to address physiological needs. That means their need for food, liquid, rest, all of that. So always put these questions into Maslow's hierarchy of needs and go by the bottom up. Let's see. Make sure you know what age groups are at the highest risk for suicide. Men commit suicide more than women, usually roughly 3 times the rate of women. Although women are more likely to attempt suicide, men are more likely to be successful with their suicide attempt. Older adults have a higher rate of suicide than younger adults. Substance use is a risk factor also. Yeah, so go over the suicide risk factors. Bipolar disorder, acute mania, you should know the signs and symptoms. Very often we'll see grandiosity, poor judgment, labile mood, and pressured speech. So labile, remember labile means changing. So we hear that term in relation to blood pressure. Labile blood pressure is a blood pressure that's low, then it's high, then it's low, then it's high. Unpredictable, just goes up and down. Same can be said with mood. Labile mood means someone who goes from crying to laughing and they're down and they're up. So labile mood. Pressured speech is sort of, they're that stunted difficulty getting the words out. Poor judgment and grandiosity. Did you know that my family owns this facility and I'm really the boss of everything? And so, yeah, some grandiose story. If someone is manic, it's best to give them food that can be eaten while they're moving around, finger foods, like peanut butter crackers or, a can of something to drink, a bottle of water, something that they can eat on the go while they're moving, while they're walking. Yeah, fish sticks or chicken nuggets or something. Anhedonia is inability to feel joy. Sort of an important definition to remember. Neurochemical processes responsible for depression are decreased serotonin and norepinephrine activity. So deficits of serotonin in blood or cerebral spinal fluid occur in people with depression. Also, norepinephrine levels are decreased. So the reason why that's important is to know how antidepressants work. Some affect serotonin, some norepinephrine, some more one than the other. And you just have to figure out really by trial and error what works best for the patient. Let's see. You should know a little bit about Freud. Um, and Freud really felt that depression is closely related to anger, and that depression is anger turned inward. That was his philosophy. Um, let's see. You want to take a look at who has the highest risk for developing major depressive disorder. And the people at highest risk will have a mood disorder in first degree relatives. That means parents or siblings, people with substance use, people who are divorced. Um, yeah, so know who is at the highest risk. I think, I've said this so many times before, but I will say it again. When a question asks you which indicates the need for further teaching, you're looking for an incorrect statement. So generally, there'll be 3 correct statements and 1 incorrect statement. So if we were talking about someone taking lithium, the statement that would indicate the need for further teaching would be the patient who says that they're going to change their salt intake. Like all of a sudden they say, well, I'm going to follow a low salt diet. A low salt diet is fine, but the issue is that they're changing their salt intake. Or maybe they say, you know what, I'm going to start drinking a gallon of water a day. Yes, it's good to have increased water intake, but the concern is the change in water intake. So anytime someone is going to change their salt or water intake, um, you're going to need to do more lithium levels on them more frequently. So if somebody is having a lithium level once every 6 months and they say, I'm going to start training for a marathon and I'm going to drink a lot more water during the day. I'm going to be running more and it's 100 degrees outside, so they'll be sweating more. You're going to have to schedule more lithium levels more frequently for that person because their water intake is going to be fluctuating. Remember, lithium is a salt. In thinking about electroconvulsive therapy, which is ECT, remember that the treatment of the patient post-procedure will be the same as you would assess a patient post-anesthesia in any setting. So that's going to be assessing for bowel sounds before they eat, turning them on their left side if they're too drowsy, if there's any risk for, I don't know, swallowing wrong or choking. Checking vital signs frequently, just as you would post-procedure for anybody. It is a procedure that requires anesthesia. So however you assess somebody post-anesthesia is how you're going to assess someone post-ECT. Um, let's see. There's so much of this that you already know. I'm not going to go through every single thing. Um, review what falls under a nursing scope of practice and an unlicensed personnel scope of practice. So unlicensed assistive personnel, like a nurse's aide, can record fluid intake, can record urine output. They cannot calculate nutritional intake. They're not going to do patient teaching. Yeah, think about scope of practice. Let's see. When a patient appears to have difficulty following through on activities, might be because they're manic. Maybe it's because they're depressed and don't have the energy. Make sure that you're breaking down the activities into very small chunks. So, you don't want to tell someone, okay, it's time to get up, pick out some clothes, and come to the group room. We're going to have a brief group and then go to breakfast. That is too much for someone who is feeling overwhelmed or manic. You could just say, just pick out a pair of pants and stop there. And then once they do that, then they can go on to the next task. Sometimes decision making and multitasking is really stressful and overwhelming. You should review extrapyramidal side effects, or EPS. This is seen in people who are diagnosed with schizophrenia and who might be taking Geodone, which is a antipsychotic drug that has a greater incident of causing EPS. Um, let's see. Okay. If we're going to use the therapeutic milieu to manage aggressive behaviors, so remember the milieu is the environment, and a therapeutic milieu is a therapeutic environment, and that is what you hope that a psych unit is. We want the psych unit to be a therapeutic milieu. For that reason, the psych unit often follows a very set schedule. Sometimes people on a psych unit, that's the only order and stability that they have in their life. And so they really need that. So you want things scheduled at the same time each day, things like meals, showers. You want things to be a very measured distance apart, like maybe the chairs are 1 to 2 feet apart from each other. You want people to talk to clients with a relaxed posture, so not with their arms folded in front of them. All of that helps to build a therapeutic milieu. Go over the different types of hallucinations. So command hallucinations is someone is telling someone what to do. A voice has a specific instruction. Auditory hallucinations is hearing a voice that isn't there. Olfactory hallucination is smelling something that isn't there. Gustatory hallucination is tasting something that isn't there. Let's see. Make sure you review positive and negative symptoms of schizophrenia. Hallucinations are an example of a positive symptom. Um, I think it's really important to note that one of the first symptoms of relapse of schizophrenia is trouble sleeping. That's really important because if you're working in an outpatient setting, like a family practice, um, or an outpatient psych setting, but really something, even something as common as a family practice, if someone has a history of schizophrenia and they start saying, you know, lately I really can't seem to sleep, I'm sleeping less and less, I'm feeling more tired, you want to really get them to see their psychiatrist or their provider, whoever it is, as soon as possible. That's one of the earliest signs is trouble sleeping. All right, let's talk about eating disorders. Um, Complications of binge eating disorder. So with binge eating disorder, the complications are related to obesity, and binge eating episodes are followed by increased feelings of poor self-image and guilt and shame. It's usually based on comfort foods. Um, so they're not often getting the proper nutrition. So you might see malnutrition, even though someone might be eating a lot. They may be malnourished. They might have type 2 diabetes. And they'll certainly have feelings of worthlessness and shame. The patients that really do well recovering from bulimia and from eating disorders in general have a really strong family support. I think that's true with any illness, especially psychiatric illnesses. When there's good family support or social support, when there's a strong support system, people really tend to do so much better. I think that's true for everything in life, really, but in particular for people recovering from mental illness. People with anorexia are really eager to please. They are generally perfectionists and really intelligent, really hard on themselves. Yeah, usually above average intelligence, very achievement oriented, dependable, eager to please, and seeking approval. Remember that bulimia is the person who eats and then purges. So it's like a binge and purge. With a diagnosis of bulimia, we generally see that from ages 18 to 22. Now, I'm not sure if your book says something different. This question is from the book's test bank, so it would be odd if it said something different, but for the purposes of testing, and I believe as far as the NCLEX goes also, the answer for bulimia, you would expect the age range of 18 to 22. For someone with anorexia, you would expect their body weight to be less than normal for their age, height, and physical health. Let's see. All right, in talking about mental health across the lifespan, and we talked, I think this is module 12, we talked a little bit about children with ADHD. It's really important for the parents to help their children build their child's self-esteem. Children with ADHD are very often scolded and criticized in school and in most situations that they're in. You know, why can't you focus? Why are you all over the place? And they're generally getting criticized by a lot of people for a lot of things. So it's really important for parents to focus on building their child's self-esteem, usually rebuilding self-esteem. ADHD is not the fault of parents or the child. That's really important for education purposes to parents, because parents will very often think it's their fault. You know, did I feed them the wrong thing? Are they just eating too much sugar? Is it my fault? Is it somebody in my family have it? Or, you know, um, also attending support groups can provide information and encouragement from other parents. Um, yeah, having a kid with ADHD can be a lot. It can be a lot for a parent, so you want to really help them get as much support as possible. In thinking about spirituality, because there is a nursing diagnosis of, spiritual crisis, which is a pretty serious thing for a patient. Spirituality guides beliefs about the meaning of life events. And spirituality is really the essence of a person's being and their beliefs about the meaning of life. This is not religion. Spirituality is different from religion. Someone can be an atheist and still be very spiritual. Um, Spirituality can really help many adults with mental illness. It can be a coping device. Um, so yeah, it's important to understand what spirituality is and help someone get in touch with their spirituality. Maybe this means that they're outside enjoying beautiful weather or a breeze, or doing artwork or journaling, listening to music. All of these type of things can help us get in touch with our spirituality. Also, mental health across the lifespan, it's important to take a look at dementia. Dementia, if somebody has dementia and they're feeling, they get really agitated in the dining area, then you can have that client eat meals in a quiet location. If it's too much for them to be around people, I mean, and that's not a punishment. That is working on their behalf for them to be more comfortable in a location that's more comfortable for them. So again, we're not doing anything to punish them. We're just trying to figure out where they are the most comfortable. Um, you will, if you work in a family practice or in a pediatric practice, you for sure will hear parents ask about, is my child going to get autism from vaccines? And really, the response is there's no research to establish a relationship between vaccines and autism. And that is per the National Institute of Child Health and Human Development Centers for Disease Control and per the Academy of Pediatrics. Of course, someone can Google information and they will find the answer that they're looking for if they look hard enough. But per those agencies and your textbook, there's no research to establish that relationship. Um, Remember that in the case of autism and autism spectrum disorder, um, there's no cure. So if a parent, and you'll hear this question a lot, if a parent asks, will my child ever be normal? Um, the response from the nurse should be, there will always be some traits. I always stay away from the word normal because normal is a spectrum, right? And we're all on any part of that spectrum on any given day. So I don't really know what normal means. I don't know if anybody does, but it means something different depending on the day, the time of day, what we've eaten, how much sleep we've had, what's going on in our lives. So yeah, so I always try to steer people away from using that term. Let's see. I think it's always a positive outcome if the client with mental illness is able to be stable for several months, even several years, even if that means that they're seeing the same case manager for 3 years, that's a big win. People with mental illness who are not stable and who are in crisis generally do not exhibit any kind of stability, like um, unable to take their meds. Maybe they're not filling their meds on a regular basis. Maybe they're not keeping a job or even staying, living in the same place. But if a client says that they've been meeting with the same case manager every month for 3 years, that's a very positive outcome for someone with mental illness. That's a big win. All right, that's it. I think you've got all the areas to review in preparation for this exam. Remember to reach out with any questions. Hopefully you took some notes and reach out with anything that didn't make sense or that you have more questions about. See you in class.